So we're going to go through about a series of briefer presentations, and we'll lead off with Dr. Gavin Bart, who's the Director of the Division of Addiction Medicine at Hennepin Healthcare and Associate Professor of Medication Medicine at the University of Minnesota. He'll talk about methadone. Thank you.
Thank you, Dr. Carroll, and thank you, Dr. Leshner. I'm very happy and honored to be here at the National Academy of Sciences for this presentation. And thank you, Dr. Volkoff, for really setting the stage, along with the rest of the panel, for much of what I plan on talking about. Certainly, methadone is more than 50 years old, and we have plenty of guidelines. The VA, the American Society of Addiction Medicine, SAMHSA, we have World Health Organization, and even this great institution, the National Academies, has addressed the issue of methadone back in 1995. So we have plenty of data about how effective it is. In terms of disclosures, I want to point out my most important one, which is I am a clinician treating opioid use disorders in a urban safety net healthcare system. So methadone, no doubt, multiple studies, including meta-analyses, show that methadone reduces mortality, both all-cause mortality and opioid-related mortality, that people in this meta-analyses of cohort studies showing that periods of time on methadone versus off of methadone, there is a reduction in risk of mortality when people are on methadone versus when they are off methadone. Similarly, people who are on medications to treat opioid use disorder have reduced risk of acquiring and transmitting HIV. And in the state of Massachusetts, looking at 17,000 people who had index opioid overdoses, being on medication during the year following that index overdose reduced the chance of dying if they were on methadone by more than 60%, and buprenorphine more than 60%, although there was not a statistically significant effect of naltrexone, perhaps due to the sample size. So there's no doubt that these medications, and methadone specifically, reduces mortality and associated risks. Retention, you'll see studies on the left here from the NIDA CTN. The top line for retention in methadone during the 6-month trial is about 75 to 80%. And that retention, and you can see in the graph below it, is dose-related. The higher the doses that people are on, if it's more therapeutic, there is a greater chance of retention and treatment. Now, I think we have biological reasons to explore predictors of retention and outcome. I have 2 separate studies that I've represented here, and the top slide in the middle in red and blue is from my clinic. This is just naturalistic in my clinic, urban safety net clinic, looking at retention, where in the general population we have about 60% 1-year retention, but you'll see the line in red. This is a specific ethnic minority where their retention is almost 80%. And in a separate study looking at these populations, we found that there were both pharmacokinetic and genetic contributions to methadone clearance that we think may help predict treatment outcome. And we'd like to be able to connect these predictors, biologic predictors and markers, to help not only create therapeutic drug monitoring, but to help delineate appropriate dosing and perhaps medication selection. Now, there are non-biological predictors of retention and treatment, and many of these are structural. We heard about some of these today. Take-home doses. So in the study, the graph in the middle, the amount of take-home doses you receive predicts your retention. And when people are randomized to a greater take-home schedule versus a more restrictive schedule where they have to go to clinic more frequently, the people who are able to have more take-home doses stay in treatment longer. Contingency management approaches to addressing take-home doses also can impact retention. And this graph on the right is actually the distance patients have to travel to get to their clinic. And there are people, who are traveling 20, 40, even 100 miles to get to their clinic. And this is definitely going to impact their access to care and their ability to be retained as they enter into remission and recovery and begin getting employment, and being able to go to these clinics so regularly impacts their ability to stay on treatment. There are certainly issues related to methadone that have to do with safety and diversion. Looking at some data from the CDC, in 2017, there were more than 3,000 overdose deaths related to methadone. Now, 2 prior reports by SAMHSA have really overwhelmingly demonstrated that, that the majority of overdoses related to methadone are diverted methadone prescriptions when used in the treatment of pain, and that methadone clinics are a very minimal contributor to these deaths. But it's important to note that the distribution of methadone and the diversion of methadone track together, and that if diversion is leading to death, we also know from work that Dr. Lafwell has done and others is that diversion is related to the access of care. So when people don't have access to treatment, there's actually greater diversion. And so the fears about diversion may actually be reduced when people have greater access to care because they don't need to take care of themselves through illicit means. They're able to access treatment. Other safety issues, there's been a lot of attention to cardiac effects of methadone. Yes, methadone does increase the QT interval in a statistically significant manner, but not clinically significant, and there really has not been a linkage to this to cardiac outcomes. We do have concerns about interactions with benzodiazepines, and all opioids have increased risk of death. About 1/3 of overdose deaths are in association with benzodiazepines. So the Institute of Medicine clearly demonstrated that methadone is an effective treatment. We don't need to debate the effectiveness of it. But piecing together the cascade of care from SAMHSA data, we see that of people who have opioid use disorders, very few of them are able to access treatment at all, and only about 25% are getting any form of medication. And when we look at formalized treatment settings, of the more than 1,300 settings surveyed, fewer than 10% or about 10% offer medications. Now, those that offer medication, most do offer methadone. So next steps, I think we can do a better job identifying the predictors of outcome. We need to have measurement-based care guidelines so we can adjust our treatment approach. Combating stigma about not being absent, not being drug-free, the fear of withdrawal, the idea that people should stop the medication in general. How many other chronic diseases do we say, you know, our goal is to get you off your medication? We need to change discriminatory practices, add methadone to the Americans with Disabilities Act, add methadone to the Fair Housing Act. We need to change the Narcotic Treatment Act of 1974 to allow methadone in jails using the same exemption that hospitals get. Hospitals don't have to be registered OTPs, but they can continue to give methadone. We should have the same standard for other controlled settings such as jails, and we need to expand access to care. Dr. Leshner, I think under your watch, in the Federal Register, there was an allowance to create the medical office-based model of methadone, and that should be revisited as discussed earlier today. Thank you.
Wonderful, Dr. Bart. Thank you very, very much.